pleasure to be with you today, this middle of September. It's hard to believe we're already nearing the end of the calendar year and all of that, but being on an academic campus, it's really the start of the year for us. I noticed today as I was walking to my office, the students kind of first round of exams have started. So you can definitely see the exhaustion starting to set in and the realization that the fun of the start of the academic year it has come to the realization of the reality of the year. But I'm excited to be here today to talk about the future of healthcare as well. For those of you who don't know me, I think I recognize a lot of names on today's call, but for those of you who don't know me, my name is Cody Mullen. I'm a clinical professor here in the Department of Public Health at Purdue University, but also a senior advisor with the Indiana Rural Health Association, where I worked full-time before coming into academia. Here at Purdue, I am the Director of Professional Graduate Education, so I oversee both our Masters of Health Administration and our Masters of Public Health programs, and I have roughly 15 years of healthcare policy and administrative work, primarily in rural health and disability health. So what is our agenda for today? What are we going to spend? Hopefully you're all enjoying a wonderful lunch. I'm looking forward to my lunch when this is over, of leftover meatloaf. Gotta love meatloaf. But where are we going to go over our hour today? So really, I want to break up healthcare into three main buckets and talk about some of the different features of where we think healthcare may be going and how that looks like. So first off, talk about payment. So let's get through that, probably the worst part of our discussion today around payment. Then we're going to look at the delivery of healthcare and how we're delivering care. And then lastly, we're going to dive into some politics and we're going to talk about the 2024 election. Again, I will say this a few times throughout the slides today. My job, my goal is not to share political viewpoints, but really talk about what are the different aspects of the different political parties and how those are affecting healthcare both in DC, but then here in Indiana within our state. As I would tell my students, my goal is at the end of today, you should have no idea my political leanings or preferences as we just talk about the facts and look at the different aspects of what the different parties are moving towards as well. So as we dive into the payment of healthcare, I recognize that we have a lot of different people on the call. Some of you are probably working with payments on a daily basis. Other views hear it coming through the pike as well. But I really want to kind of just start off where we are as a country. If we look at the actions that are being taken at the federal level under the Biden administration, we'll have a new administration in 2025, either a Trump administration or a Harris administration. As we look at the new administration coming in at the state level, as Governor Holcomb is finishing his second term, and we're looking at either Governor Braun or Governor McCormick initiating, we recognize that healthcare is a huge piece of our economy. If we look at GDP or gross domestic product, that's a measurement of how many dollars are shared within our country each and every year. If we look at GDP, it's been rising as different prices have gone up, as incomes have gone up, as we've seen stimulus coming in during the pandemic. But we are always fascinated in looking at in healthcare administration at that ratio of national healthcare expenditure, NHE, as a ratio or percentage of GDP. And we recognize that our GDP before the pandemic 2016 through 2019 was hovering between 17.4, 17.6%. And for a while, even when I was a student, we always say that's unsustainable. That's 17% of every dollar, 18% of every dollar is going to things unrelated to education or defense or leisure or activity. It's going to healthcare. And how do we reduce that? How do we transition to more of a public health mindset, population health mindset? We saw during the pandemic that this spiked, not surprisingly, in 2020 and 2021, when we were seeing a decrease in GDP. People weren't going on vacations, people weren't spending additional dollars. But we also saw an increase in our healthcare expenditures as a raw number. We saw people going into ICUs or long-term care settings for a longer period of time as they're recovering from COVID, or frankly, from the care that they could not receive due to the COVID response that then caught back up with them at the end of 2020, 2021. Notice though in 2022 that we started to see that decrease to 17.3% of national health expenditure, but our GDP went up, but our overall health expenditure has gone up. Just from 2016 to 2022, so a period of 7 years, we saw a $1.1 trillion increase in national health expenditure. Again, we recognize that That's good, right? People are getting the care that they need. All of us work in some way, tangentially or directly, in the healthcare system. These are dollars that are going towards our paycheck, going to the programs that we deliver and execute. But it also has a growing target on the back of healthcare. How do we see politicians? How do we see employers really trying to reduce healthcare expenditures? Like I said, I work here at Purdue. Healthcare is a large expenditure. We have a lot of employees, and we're getting weekly and monthly emails from HR of like, hey, we now have this program with this healthcare provider for this service, either joint or colonoscopy or cancer or surgery. And if you go there, we'll have a reduced out of pocket for you, trying to drive us to this. So, how do we, the future of healthcare, how do we as rural facilities prepare for that? How do we creatively build ourselves to be prepared for that? We look out further, if we look at the national health expenditures estimates over time, so this is projections. This came out a few years ago. There's not been a good one that's come out since. So 22, 23 is still projected, but notice 22 is at 17.3% GDP. We projected 17.4. We anticipate by 2031 to be at 19.6 GDP. So there's going to be a lot of discussion happening both at the federal and the state level of how do we reduce that? How do we prepare? So I ask you at your facility, what are the creative programs? I know several of you are working really hard doing everything that needs to be done, but what are those added programs that you could offer to really connect with employers, to really connect with Medicaid and Medicare? Later on, we're going to talk about managed care and what that looks like. But how do we really support that? And how do we prepare for maybe external factors changing the way we deliver healthcare forward? We look at payment. So we go all the way back to 2010, and I just made myself feel kind of old when I said when we go all the way back to 2010. But when we go back to 2010 and we look at the initiation and the discussion of the ACA, really that started in 2009, it was passed March of 2010, we saw this huge movement in the payment of healthcare of how do we move away from a fee for service, less aggregated, per click and away way of paying for healthcare. How do we migrate away from that into a more aggregated payment model? And we talked about accountable care organizations, this maybe several of your facilities have participated in. We looked at this idea of DRGs, diagnostic related groups, and how did that look at. We then went all the way to the full aggregation of a salary-based care, very similar to what the VA does as well. So we're looking at all these things. So what are we as a facility? I use this slide a lot when I teach in classes to kind of talk about the changes of those. What are the motivations from a payer, from a provider, from a patient standpoint for each one of these different payment mechanisms? But I also have to pause of like, I created this slide 8 years ago. I created this slide when I first started teaching about 2014. I guess that's 10 years ago. About 10 years ago in 2014 when I first started teaching, because we saw that the start of the ACOs and we really saw that transition occurring, but we started to slide back towards fee for service. And as we move back towards fee for service and DRG, we've seen value-based care metrics through MACRA and MIPS come in there. But we have to be prepared. What will come in 2025? What will come in 2026 and beyond? As we're looking at these payment models, we recognize that there's a lot of barriers to the capitation payment model. Especially in rural, it requires a large patient population. Most rural communities don't have the patient population for the risk to be distributed equally and fairly, so you have to partner externally. So how do you as a health system, as an independent provider, partner with other independent providers? How do you partner with large systems? In our state, I'm thinking Ascension, IU Health, Community, Franciscan. How do you partner with them? Or what's that new relationship in contracting where a more aggregated, more risk being brought in can support you moving forward? Through the ACA, we saw the initiation of CMMI. If you're not familiar with CMMI, CMMI stands for the Center for Medicare and Medicaid Innovations. It is part of CMS, Center for Medicare and Medicaid Services, and it was the arm of CMS that was created under the ACA to really say, how do we test innovative new ways of paying for healthcare? How do we change the paradigm if we do those? With an overall goal of a health system that achieves equitable outcomes through high quality, affordable, person-centered care. I think we can all agree, right, that we want high quality healthcare. We want affordable healthcare. We want person-centered care. Even us as a patient, I want my care team to know who I am and know my story and be able to walk beside me through all of those things. In there, we had 5 strategic goals of CMMI of driving how care, advancing health equity, supporting innovation, addressing affordability, and partnerships to achieve system transformation. Notice here, all but one of these doesn't deal with payment, right? There's address affordability, which is green and has the dollar sign. But as we're looking at these ideas, it's really about the outcomes that we see our patients are. So what's the aim for Drive Accountable Care? It's to increase the number of people in a care relationship with accountability for quality and total cost of care. How do we move across that table to that more aggregated, or sorry, least aggregated side? How do we get higher levels of reimbursement? For incorporating those? How does Medicare Part A and Part B come together in that care relationship? How do we prepare your health system to be ready for those? Next is advancing health equity. The aim there is to embed health equity in every aspect of CMMI's models and increase focus on underserved populations. Rural is classified as an underserved population by CMMI. So there's a unique focus of, okay, this model works in LA, this model works in Detroit, this model works in New York City or Chicago, heck, even Indianapolis. But how does it work as we get away from those into more rural and or frontier areas? How does the model need to change? And we're starting to see a lot more discussion of that at the national level. I'm on the board of trustees for the National Rural Health Association. We're having a lot of discussion of, yes, the model has worked in Indianapolis, but how does that model work when we get, an hour away from the metro area? What needs to change and tweak? And CMMI has been very open to that. How do we support innovation? How do we leverage a range of supports that enable integrated person-centered care such as actionable practice-specific data, technology, disseminations of best practice, peer-to-peer learning collaboratives, and payment flexibilities? How do we really support all of those things? As we look at different sets of data coming out, how are we prepared to respond and address to some of those things? Next is improving access by affordability. How do we drive our costs down? How do we pursue strategies to address healthcare prices, affordability, and reduce unnecessary or duplicative care? I always pick on my family when I give presentations, but I'll give the example of my father. He's a Medicare recipient. He's over 65, but he also served our country in Vietnam, and he's on the VA. I'm amazed at how many times he has the exact same thing done across both health systems. And it's not because he wants it done twice, it's just the way the system works. So how do we creatively not reduce the care that's needed, but reduce that unnecessary care? How does the rural site become more integrated in with the urban site? So as patients are more translucent, sorry, can't speak. As patients move around more frequently, how do we ensure that the health record follows them around? Then lastly, we want to partner to achieve systems transformation. The aim here is to align priorities and policies across CMS and aggressively engage payers, purchasers, providers, states, and beneficiaries to improve quality, to achieve equitable outcomes, and to reduce healthcare costs. So how do we partner with industry outside of healthcare? How do we partner with large employers? How do we partner with state Medicaid? How do we partner with private insurance? How do we do all those partnerships? Now, I bring all these things up because CMMI is an item at the federal level that's discussed a lot. Is this an agency? Is this an institute that we really need in healthcare? What are they doing? So we look at their future goals and their strategic plans. Notice that, there's a lot of activity during the Obama administration. We saw some transitions during the Trump administration in 2017 to 2019 with the CPC Plus and the MDPCP model. What's exciting to me as a researcher, as an academic, but also as someone who works in healthcare and has a family member currently laying in a hospital bed right now, is that we're starting to see the data coming in. We're starting to see the long-term effects of FQHCs, comprehensive primary care. We're starting to see the data of next-gen ACOs and ACO investment models and the pioneer ACOs. We're starting to see all those things come in to really have a discussion of, okay, this worked really well. It took time for us to say this worked well, this did not work at all, right? Or this made things worse. So we're starting to see a lot of discussion. But it's interesting as we look at the Supreme Court decision from this summer about executive authority versus legislative authority, Congress is going to be a lot more engaged in some of these discussions and decisions moving forward, and really be able to support some of those actionable steps moving forward. So what do we think the next models are going to be? We've not seen CMMI release a lot of models. Usually those happen early parts of an administration, so they can be put out for funding, can be bid on, be implemented, and then early results can be discovered by the end of a presidential term. I know these things should not relate to politics, but they do. So how do we support those things moving forward as well? So I think it's being prepared for what are the next innovation models, or what will happen if CMMI is closed, which is an honest discussion occurring in DC across both political parties. I'm not picking on one party at all. Both political parties are saying, did CMI achieve its goal over the past decade? Is it on the right steps, or is there a different approach that we should be taking and how we transform the delivery of healthcare? We also recognize that CMMI has a huge 2030 goal. The Center for Medicare and Medicaid, CMMI, aims to shift 100% of Medicare beneficiaries into an accountable care relationship. So that could be a Medicare fee-for-service relationship that has value to it. That can be an ACO with one-side risk. That can be an ACO with two-side risks. And we're seeing that transformation that's occurring. I also like this slide because we're showing the enrollment that we're seeing, right? So in 2021 for CMMI, there's about 58 million Medicare enrollees. By 2030, it's going up to 77. And we're seeing Medicare Advantage, which they're calling an innovative model. We'll talk about that in a minute. I'll be guarded with what I say, but we'll talk about that. Growing from 27 million to 41 million. And then that ACO model, Medicare fee-for-service one or two-side accountable care model, to be the rest. So everyone will be in some accountable care model. 2030 is not that far off. We're talking about 6, 7 years. So if we're looking at program development, how do we as a health system be prepared for that? The other thing that we need to look at is this idea of employer-led transparency initiatives. So hopefully, maybe not hopefully, I'm assuming majority of you have been involved with or have heard about the RAND report. These first came out prior to the pandemic. We are now on RAND report 5.0. That has come out, and this is looking at employer data and what employers are actually paying for care in relation to what that costs towards Medicaid. These reports are highly debated. Methodologically, I would say there could be potentially some improvements to methodology. This is being recorded. There's a lot of concerns with these reports, the way they're conducted, but then there's also a lot of fallout that we've seen from people who've processed these findings, because it shows that, especially on RAIN Report 1.0 that looked only at Indiana, it broke up health systems and showed how some health systems are disproportionately being paid much more than other health systems within the state for like care. And rural had its own list there. I mean, rural was below average, surprise. But we've seen over the next 2 years, they've done multiple other reports looking at additional states. And this is from 4.0. I didn't have time to make the 5.0 slide. It shows the same, right? That there's great variation between what different states are paying. Indiana towards the upper end. So it changes the conversation around price transparency and reporting. It changes the conversation with employers who may not understand the intricacies of this data, probably do not. They're going, well, we're paying more than Medicare. I just want to pay what Medicare pays. And all of us in healthcare recognizes that doesn't work, right? We can't really support that moving forward. But how do we prepare for that? How do we support that? How do we have those discussions? Because the employers, the Chamber of Commerce, are getting this report and they're arguing with that. So how do we as health systems, how do we as administrators in healthcare, how are we prepared to have that discussion and not just hide away from it? I make all my students read the RAIN report, and they all have to write an essay on it to really argue with me about why the report is flawed, and what are the flaws there, but also recognizing that, it's easy to look at the data and say quickly, like, hey, I think I should pay less. Let's have that discussion, which then opens hopefully a greater dialogue about how does healthcare get paid? How does Medicare and Medicaid and private pay mix in to ensure, especially in rural, that our hospitals are able to stay open, right, and able to stay in the back. We also need to look at private pay. So we look at United Healthcare, we look at Blue Cross Blue Shield, we look at Aetna, we look at all those different providers. We're also going to talk about managed care. We're going to talk about Medicare Advantage and what those do. I mentioned I have a loved one in the hospital. He's actually at an LTAC, and I had to sit in on the peer-to-peer that occurred for that LTAC admission to be approved by one of the payers on the screen. I won't say who because this is being recorded. But it's interesting to see that relationship that our payers are now having, not just the government, but our for-profit private payers are having in that relationship moving forward, with the way we deliver care. As we look at managed care, both at the Medicare, but also the Medicaid level, Indiana, we had Pathways that was developed. That was a 5-year transition that occurred for the 16 and older who went on the Medicaid waiver. It's being managed by private entities, Anthem, MedWise, CareSource. I think there might be another one that's there. It might be United or Humana. I'm sorry that I forgot about that. Private pay, it's also being there. We're starting to see more and more consumers saying, "I'm just going to get my own insurance." We're seeing a movement. If you're familiar with in Zionsville, there's a surgical center. I believe it's still open. They don't take insurance. If you go to their webpage, it's like going to Amazon and they list all the surgeries they do, gives you all the options, and you just walk in and say, "Okay, if I need my knee scoped, it's $8,000. Here's $8,000." And how do we transition to that? To be honest, the way I learned about that health center was Senator Braun, and we were visiting DC, brought it up during our meeting and said he thought it was a very innovative model. So these are things that our elected officials are looking at, our employers are looking at, of how do we change things moving forward, and look at that. We also have to look at the long-term burden of COVID. I know we don't want to talk about COVID. I'm in public health. I feel like every lecture I give, the word COVID comes out of my mouth. I don't want it to, but it's fundamentally transformed the way. But we also are looking at patients who didn't receive care for a prolonged period of time because the system wasn't able to. Nothing against anyone on this call, but how do we prepare for those long-term costs, and what are the payers going to do around that? So that's going to drive to this discussion of the delivery of healthcare. So we talked about the payment of healthcare. We're talking about now about the delivery, and then lastly, we're going to get to the politics of healthcare. So COVID, right? This picture, for a few of you, if you're eating, you may have felt that food kind of come back up the esophagus a little bit, right? None of us want to go back. We were talking prior to this in the backstage of the webinar with some of the NRHA team members and colleagues about COVID, right? And looking at the things that we did in 2020 and 2021, going like, can't believe we did that, right? I can't believe that was how we responded, but we did. Well, how do we prepare for that next one? I always tell my students, like, if you thought COVID was a once in a lifetime, I don't think it was. I think we're going to have other pandemics that are going to occur in our lifetime, and I don't think that far away. Now, are we going to go through the full shutdowns and school closings and all of that? Probably not. I don't think that's going to happen. I think we learned a lot. I think maybe some of those responses weren't necessarily the best, but based on the knowledge we had back in 2020, it's always easy to be the Tuesday morning fantasy quarterback looking at my team like, I did pretty good. I had no clue what I was doing last week. I just put people in and it worked out well. So how do we prepare for that? We have an Mpox outbreak right now, right? And we're seeing that H5N1 and the transmission. Bioterrorism. So how do we as a healthcare system prepare for that? How do we ensure that we have adequate supplies ready and rotating our stock? How do we build the cash on hand to buy the excess supplies to be able to have, right? These are not easy, like, oh, just go and buy an extra 5,000 N95 masks. Okay, well, I don't have, those are probably what, $2 a piece, $3 a piece. I don't have the $15,000 to put in my warehouse. I don't have a warehouse. I have to buy a warehouse. So how do we as a health systems prepare for those things? How do we ensure that our messaging for patients are going to be appropriate and supportive of that? I also love this idea of that this model from Robert Wood Johnson, the county health rankings model, have of looking at what other factors affect health outcomes. And they measure health outcomes of morbidity and mortality, length of life, and quality of life. And they show, and I'm sure this is data that 20% of your outcomes are driven by the health care that you receive. That's what goes on in my provider's office. What goes on when I go visit my pharmacy. But 80% of my health outcomes are driven by things that the healthcare system historically, prior to mid 2000s, didn't really look at, right, in that fee for service model, or didn't directly look at. So we're seeing this change into social drivers or social determinants of health. I prefer drivers because I think they're modifiable. Determinants mean I am this, so this is my outcome. Where a driver says I am this, and I have the ability to change that driver to change the outcome. But we look at health behavior. 30%, 1.5 times the clinical care is health behavior. So this is, do I smoke or vape? What's my diet and exercise? What's my alcohol and drug use? My sexual activity, as we look at STDs and STIs. Social and economic factors, education, employment, income, family and social support, community support. That's double of healthcare. So as health systems are moving more to a value-based payment mechanism, as we're having more risk associated with reimbursement, as you just saw us in the previous unit, How do we move forward and how do we prepare? Because these factors, are now going to have to work directly with these factors. Because if I'm going to be paid on the outcomes, the length and quality of life, I'm only focusing on 20% of what drives that outcome, I'm not going to be very successful. I need to get involved in health behavior. I need to get involved in social and economic factors. I need to get involved in physical environment. But in a rural setting, how do we prepare for those when our staffs are already doing three jobs? As people leave, it's not like, oh, we immediately were able to backfill that person. Either we just on the budget to backfill that person, or we're not getting quality applicants and the position staying open on the job boards longer and longer until we're able to fill that position. So how do we innovatively look at like community health workers or care navigators or other supports that come over and help someone on diet and exercise? Can a provider have that discussion? Absolutely. Absolutely. But could a community health worker come in and say, hey, I'm going to be at the Y and we're going to do a walking group on Wednesdays at noon. Let's all go over to the Y or the school fitness center or the employer's fitness center, the hospital that open up to the public. How do we recreate and change some of those paradigms and build our health system to those? We also have to look at mergers. This is about a year old slide, over a year old now, but we're seeing these mergers. So Kaiser merging to Geisinger. So Geisinger is a large health system. They actually owned a university, large health system that was purchased and acquired by Kaiser. That was out on the West Coast. We're also starting to see more of these large system mergers happening. So 10 hospitals merging with 10 hospitals, not just the large area health system looking at merging or purchasing or partnering more closely with that local rural hospital, but these large health systems merging. We're also starting to see, and I'll talk about this on the next, well, I got ahead of myself, this idea of private equity. To really changing that relationship of individuals who say, you know what, I can make money off people's health, so I'm going to buy, and we're seeing this a lot in rural, buy a rural hospital and convert it into a for-profit center with private equity owning it. CBS News, it's the main channel in Lafayette, so I'm not saying CBS is the best news out there, but it's the main channel in Lafayette to get local news. Um, has the ability to really demonstrate, excuse me, really has been doing studies about this idea of private equity being involved in healthcare. And what's that doing? Because once the hospitals are no longer profitable, what does private equity do? Close, right? And what's that do to the community? I'm going to go through these slides. I have several map slides here. This is from the Chartist Center, which is a partner of the NRHA. They're the ones that do the hospital closure analysis. I only have one slide looking at hospital closures, maybe two, but really talking about what is the changing landscape of rural for healthcare delivery. We recognize that our rural hospitals are really struggling, right? They're really struggling to stay open. There's a lot of factors at play here, right? It's not a simple, easy solution. Hey, just do this and you'll be fine, right? And it's not from a lack of trying. There's just a lot of factors, and some states have been hit differently. Indiana, you may disagree with me, but we are probably one of the more fortunate states with a Medicaid expansion because we're seeing hospital closures disproportionately occurring in states that have not expanded Medicaid post the Affordable Care Act or the ACA. But if we look at hospitals operating at a negative operating margin, right, that's not good. Notice that Indiana is a lighter color here, right? We're about 21 to 40%. There's other states, Kansas, Wyoming, New York, where 81 to 100% of the rural hospitals are operating at a negative margin. That's terrifying. Indiana, we're about 21 sorry, we're at the 41 to 60. We're at the third tier. But a good chunk of the state is at that tier. Utah is 0 to 20%. If we look at this idea of managed care, I told you we'd discuss it, but I mean, there's a lot of areas around Medicare Advantage where they're setting prices, where things are not occurring the way they should. That's driving rural providers away from being able to offer healthcare services, or not be able to take managed care, or frankly, to shut their doors because their reimbursement is dropping. Notice that in Indiana, we're at 41 to 50%. We're towards the upper end of managed care. We are the home of Anthem. We're the national headquarters of Anthem. So we've seen a higher adoption of that. NRHA, IRHA, our government affairs director, Dan Hardesty, has actively been working on advocating for how do we ensure that Congress and CMS puts well thought out policies in place to ensure that this doesn't become a larger issue than it already is. But it's a really hard battle to fight, and I give kudos to Dan for the work that he's doing with that, because it's really hard. Hospital closures, they said I'd have one slide on here. These are the hospitals that have closed. To notice Indiana, we're at 3. Rural hospitals that have closed or ceased inpatient care. This slide gets a little dicey because we have rural emergency hospitals that we'll talk about in a minute, which is technically a closure of the hospital because that inpatient unit is closing. But if we look at the states where we have greater than 10 closures, and notice that goes from 5 to greater than 10. There's no 6 to 9, right? You've had 5 or less closed, you're greater than 10. And then if I were to overlay a map of states that have not expanded Medicaid, guess what? Georgia, Texas, Tennessee, Kansas, and Missouri. Missouri has, I believe, recently expanded, or they have a ballot initiative. I know they're working on it. Have that overlay. So we saw that expansion of Medicaid, that reduction in bad debt to be a huge support. If we look at hospitals at risk of closure, Indiana, we are not one of the worst states. We're actually towards the upper end. This is good and this is bad. I think this is good in the fact that our state is relatively stable. Our state is doing good things. Our state partners, again, that Dan is working with, and Dr. C.A.R.E, our CEO, has been working with closely, has all been really good because it helped our rurals. But it also means that a lot of attention is not being set on Indiana, right? We're towards the bottom of the list, which means we're good in comparison, but we all recognize that rural, I apologize, there's a fire truck going down the street of Purdue. If you've heard that, we recognize that Indiana is very different. Or sorry, at the bottom of the list. Therefore, the new CMMI initiatives may not be ones that are a good fit for us, because we're not in that dire like Nebraska, like Tennessee, like Florida, that are that really dark, greater than 41% of the rural hospitals are at risk of closure. We're still at 10 to 15%. That's still 3 to 4 hospitals. It's still really, really scary. In addition, we're seeing that while the hospital may not close, the loss of OB services from 2011 to 2021 has increased exponentially. And this is causing a lot of harm for women, especially those who are at the childbearing ages and looking to have a child, of making decisions of where to live and wanting to be able to deliver with an OB service at their local hospital without long transport needs or long travel time related to that. Again, Indiana is towards the bottom of the list, which is good, but also means the attention is probably going to be spent more in the Appalachia, Pennsylvania, West Virginia, down in Florida. Again, the work that Jonah Wishmeyer and her team is doing with Healthy Start, it has been earth-shattering, great, right? The outcomes are things that you dream about occurring. But how do we prepare for those things? How do we prepare for if OB closure? And frankly, some of this is not financially related. Some of this is we just don't have enough OBs. They don't want to come and do every other weekend on call. They don't want to be the only OB at their facility doing all of those things as well. I mentioned that we would talk about REH, so Rural Emergency Hospital. We always said CA. REH has now become the RA model. I'm not sure I like that, but I wasn't asked. They didn't pull me to say, do you like RA? But the RA model. So rural emergency hospitals. We don't have any states in Indiana yet that have adopted this model. But it's interesting by 2 fronts. This movement started under the Trump administration and was continued and amplified under the Biden administration. So I think we can say this is a bipartisan model. One administration started, the other administration did not end it, and they've continued it and added on to it and in a way strengthened it. And we can talk about some of the pitfalls during the Q&A session at the end. But it's closing the inpatient services, which for a lot of health systems, that's a really scary thought to say we're no longer going to be inpatient. For some, that means we're no longer going to be a hospital, but you're still a hospital. You're still offering a full service emergency department that has, whatever level trauma you are for your area, maybe a level 5 or level 4, maybe even a level 3. You still are going to be offering observational services. So if that patient aren't sure if they're due for admission, you do have some inpatient overnight beds that they can stay either within your ED or your old inpatient services. You then exclude out the acute inpatient, and then there's optional services, the outpatient, the skilled nursing, the rural clinic, the ambulance service. And the reimbursement model, again, I have a whole presentation I can do on REH. It's a whole nother hour-long discussion, really changes that relationship and really changes the way that you're able to offer care because the reimbursement changes of really being that outpatient center. But this requires a really strong connection with an urban acute care facility for transfer, because if you have a full service emergency department, there are some patients that need more than 23 hours of OBS. They need a full admission. So what are your ambulance services? What's Kathleen Livingston's working on that with our InTalk network of how do we ensure that we have appropriate transfer services? Are the urban facilities prepared to receive all of that? We've seen the REH model go through a lot of adoption. It's interesting being at the national meetings, listening to, I call them the old timers. I know I'll be there at some point, who are around when the COM model came out, and everyone's like, this is stupid. It's not going to work. This is awful. We're not going to do it, blah, 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 blah. And now we have, what, 1,500 CAWs in the country? And hearing similar things coming out about the REM model, and the old timers like, we said that about the CAWs, and now we have 1,500 CAWs. Let's give this a fighting chance. And we're seeing CMS and TMMI and states really being proactive to say, okay, this isn't working. Let's tweak this. This isn't working. Let's add this. Let's change this. Let's remove this moving forward. Another area is cybersecurity. Um, if you're affiliated or have heard about Ascension, I had a loved one who was admitted during that period of time when their whole EMR system was down for about 6-ish weeks because they were hacked. The Hancock Regional, a wonderful 60-minute segment that you can go out there and watch. Right, we have these barriers to access to care. So as new technology is coming on, as we have more and more dependence on technology in our delivery of healthcare, how are we prepared for cybersecurity and those hacks moving forward? The other idea here is blockchain, right? How is blockchain going to deliver the way that we deliver healthcare? Don't ask me what all this means. Blockchain, we have CS professors here on campus who have had lunch with, who have tried to explain it to me, and it's just not clicking for me. But it's changing the way that we can utilize data and transport data. But do we have the technology in rural that can support these larger data files and the internet broadband, the ITN network, the Alley, who's just on, is the director of, who introduced me, and supporting all these things? Do we have the infrastructure, the CPUs to operate all those things? Are patients comfortable with all those? Becker's, if you're familiar with Becker's, they've had a lot of discussions about blockchain. They have a meeting coming up, I think, a week after next up in Chicago. I think it might be at Navy Pier, maybe it's back to the Hyatt off the river. Really talking about these things. And it's fascinating, the potential of blockchain. I encourage you, be on the lookout for these. I think, I'm 35, right? I'm early career. I for sure think that there'll be blockchain in my career, widely adoptable. The other area is artificial intelligence. We're all using it in ways that we don't even recognize anymore. If you iPhone got the new iOS 18 update, you're probably also receiving some of those things, and Copilot if you're an Office user, Microsoft Office, and ChatGPT. My student earlier was in a meeting and we're like, hey, we don't really fully understand that. Typed into ChatGPT. I'm like, I understand it now. But how's this being integrated into clinical care? How is this looking at radiology? How is this going to be able to provide telehealth services? How is this going to be able to support providers and care team members so they're able to offer additional services with the security of AI? Again, what happens when cybersecurity goes out and we don't have our AI? But how are we prepared for that? Okay, so now let's get into the politics of healthcare. Again, like I said at the beginning, my role here is not to be political, to look at what each party is doing. Each party is doing some really good things. Each party is doing some things that I'm not sure make the most sense at this time in our healthcare system, as a country. But we can't not look at politics, because 50% of our reimbursement comes from Medicare and Medicaid on a national average. That's federally and state funded. So we have to look at what's going on in DC. We need to look at what's going on in Indianapolis. We have an election in less than 50 days, where the House and the Senate could, potentially change in their majority. Currently, our House is Republican controlled, our Senate is democratically controlled, the White House is democratically controlled with Biden. But all three could switch, could stay the same. We don't really know what will happen in 2024. And I'm not going to get in the polls and have that discussion. Happy to do that offline when not being recorded. But if we look at what's going on in 2020 under the Biden administration, so we saw the signing of the IRA, the Inflation Reduction Act. You're probably like, why are we looking at the Inflation Reduction Act? Well, this is the act that allowed for the negotiation of drug prices. And we started to see a lot of the changes happening in Medicaid. I'll give full credit. President Trump was the first one to really say we need to be able to negotiate drug prices for Medicaid. It makes zero sense why There's logic, I know, but it makes zero sense why we are not allowed to at the Medicaid level. The Congress at the time was not supportive of the idea. President Trump tried a lot. President Biden, pardon me, came along and said, "Hey, we really need to do this," and he was successful in getting across the finish line in a bipartisan fashion. So that allows for about 10 drugs to be negotiated now. That's going to grow over the next decade, moving forward. But that was really a significant thing that occurred moving over on under the Biden administration. We also saw that we're post-COVID, so there's a lot of legislation around the CARES Act and things like that. Towards the end of the Trump administration, at the start of the Biden administration, of how do we respond to emergency preparedness. I personally, one of my news sources I love to look at is Politico. It's a non-political area. It gives a lot of great news about what's going on in DC. If you go to politico.com/health-care, so health-care, it really shows the highlights of what's going on in healthcare. And I screenshot this morning. I screenshot every time I do a presentation just to say these are what the pressing issues of the time are. And I think it's really showing, and this goes all the way back to early August, or late August, August 20th, right? We have a lot of discussion still around reproductive rights, abortion, the Roe v. Wade decision that occurred there. Harris's and the Democrats saying that should be overturned or changed or codified in code that abortions are a federal right. Republicans, are disagreeing. That's still a highly discussed there, right? We're seeing, Trump with pro-life. We're seeing Harris with pro-life, and all those things. We're seeing here in the middle, right? Our Surgeon General right now saying that parents can't function. They're so stressed, which is a formal Surgeon General warning about parental stress. Behavioral health is, again, a whole nother presentation that we can give here. We're looking at a miracle molecule that could cut fentanyl deaths in half. The opiate epidemic is still here, right? It's worse than it's ever been. When Dr. Amna Anwar started the NRHA program, and Ali was involved with that as well. We were seeing about 50 to 60,000 deaths a year. Now we're seeing close to over 100,000 deaths. It's exponentially increased over time. We're seeing confusion about the COVID shot. All these things are still flowing around and politically are still being discussed about quite a lot. So as a health system, how do we prepare for those things? How are we prepared to have those discussions moving forward? I think it's important also to look at what would occur, if it goes Republican, 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 House, Senate, White House. What were some of the things that we anticipate occurring? And then we'll briefly be able to talk about what are some of the things we anticipate the Democrats doing. Again, I'm not here to be political, but I think it's just important to recognize that these. So this comes from the American Healthcare Act of 2017. So it's about 7 years ago, 8 years old. So when President Trump was initially elected for his first term, he recognized that we need to update and change and eliminate some of the parts of the ACA, the Obamacare things. Paul Ryan was the Speaker of the House at the time, and he was also of support of these things and had been trying to do a lot of these things while President Obama was still president. But we anticipate, a new Trump administration, if they were to win in 2025 or in 2024, this changing of the of some of the things in Obamacare that we now take for granted. So in their version of the bill in 2017, what were they looking to do? They're looking to dismantle the Obamacare tax. They're looking to eliminate the individual's employer mandate, prohibit health insurers from denying health coverage, helping young adults access care and stabilize the marketplace. So things that no pre-existing conditions, kiddos can stay on their parents' insurance through 26, but changing some of the taxes in the way that we reimburse these things. On this slide, I want to highlight, we're seeing a lot in the Republican area talking about block grants with Medicaid. So taking away necessarily some of the authority at the federal level of saying this is what Medicare must do, this is what Medicare must provide, and moving more into a block grant where states can customize that model. On one way that's really exciting, right? That states are able to say make a model that works for all Hoosiers in the state of Indiana, or all Boilermakers, as I like to say. But it also changes the financial responsibility of the federal government. In a block grant, we pay this much, period. Anything above and beyond that is up to the state. Where in current Medicaid talk, it's a percentage. And it's kind of an unlimited percentage. If the state's willing to pay up to, that amount, they can match it with federal dollars. And it's usually, depending on the dollars, 40 to 60, 10 to 90, things like that. So as we're looking at a potential Republican-controlled White House, this idea of Black ransom being prepared as a health system. We also see in point 8 helps Americans access rural healthcare, providing a monthly tax credit between 2 and 14K a year. So moving away from current payment models, moving more into very high deductible health plans, and then having tax offsets to support those are higher deductibles. Again, what will this do for rural as we recognize that bad debt is something that's growing in rural facilities, really changing the way we see things there as well. What do we anticipate with the Harris administration? It's really hard to tell because they are so new. We've not seen a lot of those documents. They're starting to come out of their pressers as well, but we would anticipate the continued expansion in the ACA. We would anticipate the continued expansion of CMMI. But the question is really going to be, is it going to be single party control of all three entities, the House, the Senate, and the White House, or are they going to be split, and how are they going to be split? Is it going to be the House and the Senate are together, which is the opposite of the White House? One chamber, the House or the Senate, is opposite of the other chamber and the White House. I mean, there's a lot of combinations that we really don't know how that's going to happen. We anticipate, and historically we see, if we see all three of those, House, Senate, and White House, being together, we do anticipate more action to occur because they'd be on the same page. We saw that under the first 2 years of President Obama. We saw that under the first 2 years of President Trump. We saw that under the first 2 years of President Biden. It's very common over the last 3 presidential transitions that to occur, but for the rest of their term, or their second term in President Obama's case, we see that split, and action is more bipartisan moving forward. Again, it's important that if we look at the future of healthcare, to look at what all that's going to do. So what does it mean, right? What does all of this mean as we look at the future of healthcare? It's meaning that politically, we need to stay active. We need to stay informed about what's going on. When I say active, I mean informed and educated. It's up to you if you want to, participate. I hope everyone votes, but how active you want to be moving forward. If we look at payment reform, it's important to focus on what CMMI is doing, what CMMI may or may not do in the future, but it's also important to look at what private pay is doing. We say 50% of healthcare is paid for by the federal government and the state government and Medicare and Medicaid, but Medicare and Medicaid is starting to transition a lot more of that care back to the private sector through managed care contracts. So working and partnering with those managed care contracts as they may be changing more frequently, looking at waivers moving forward. Then lastly, looking at technology and being prepared for what technology may do, and how are we prepared as a health system. So with that, I'd like to thank you. I want to make sure I left about 10 minutes for a Q&A.